I'm Dr. Paul Cagle, and this is my advanced class on subscapularis repair with shoulder arthroplasty. In this chapter, we'll be going through a live surgical procedure and the steps of repairing a subscapularis in a shoulder arthroplasty. We're going to be focusing on getting good fixation of the sutures into the tendon, repairing the tendon into an anatomic position, as well as taking advantage of some of the tips and tricks we can utilize to get the best and most robust internal construct we can. My preference is to perform these procedures in the beach chair position. This allows excellent opportunity to see the shoulder, and this allows a great opportunity to mobilize your subscapularis. In preparing for this, you do want retractors. You're going to want retractors to be able to retract your deltoid muscle away so that you can adequately see your subscapularis, and you may need more medial retractors as well in the occasion that you need to do some releases of the capsule or the ligaments that are attaching to the top of your subscapularis. In order to make the suturing portion of the tendon more efficient, sutures of different color or of different patterns can be chosen. My preference is to use a heavy type braided type suture or a number 5 suture. This allows fixation into the tendon and allows you the opportunity to keep these sutures organized while passing them later in the case. In preparation for repairing the subscapularis during an arthroplasty procedure, my preference is to utilize a metallic button. The metallic button offers a multitude of advantages. That being that you can organize your sutures over a rigid structure. This allows you to take advantage of being able to place the button adjacent to the biceps groove and utilize some of the more dense bone of the proximal humerus, as well as it offers a post-operative radiographic landmark that can be followed and give you the security to know that your repair is intact during your mobilization process. So in the following section, we're going to be reviewing the repair of the subscapularis in a surgical procedure with a shoulder arthroplasty. In this case, we'll be repairing the subscapularis utilizing a metallic button with 4 holes here. These 4 holes allow us to pass multiple sutures through the button itself, allowing us for these sutures to be tied over the button, providing adequate fixation. In this case, the sutures are going to be passed through the subscapularis. They're going to be passed through the tendon in a way that allows for the subscapularis to be reduced to its anatomic position. Once the subscapularis is reduced, the button is going to allow us to repair the subscapularis tendon along the lesser tuberosity. By using the lesser tuberosity in the biceps groove, you take advantage of the more dense bone of the proximal humerus, providing an adequate repair. So let's take a look at the surgical video. So in this case, we're going to be examining a 64-year-old gentleman who had end-stage osteoarthritis. This individual has failed conservative management and has imaging that demonstrates end-stage glonohumeral with an intact rotator cuff. Here we're going to be able to elevate the tendon with a peel technique. So we're getting a full thickness release of the subscapularis so that we have the full amount of tendon to ultimately repair at the end of the procedure. We do need to release the tendon. So here we're showing the capsule and the undersurface of the tendon being carefully released to appropriately mobilize the subscapularis. Following this, we're going to place 2 drill tunnels through the lesser tuberosity. So this is after we've done our humeral head cut and at the end of the case and we're preparing to repair the subscapularis. Here a passer is utilized, and this allows for us to pass a passing suture. And this is a passing suture that's going to be passed through each of the drill tunnels, ultimately allowing for the final sutures that are going to repair the subscapularis. This is a demonstration of the repair that's going to be passed through. You can use 2 or 3 drill tunnels based on your preference. The subscapularis is sutured with a heavy braided number 2 suture. This allows adequate, appropriate fixation for the tendon repair. As we look at it here, you'll see that the starting point is actually slightly medial to the tendon edge. This allows for the exit of the sutures to be reduced to the medial aspect of the bone tunnel, allowing for a more anatomic style repair. As these sutures are passed, they're passed carefully for 2 Krakow running sutures. These are going to be run on the top and the bottom of the tendon, allowing for the entire tendon suture area to be covered. Following the running of a Krakow style suture, a heavy number 5 suture is then placed in a Mason-Allen style fashion. This can be seen done here at the top of the tendon and will be repeated at the bottom of the tendon. This allows one limb to exit from the inferior and one limb from the superior surface of the tendon. This provides us with the distinct advantage of allowing the inferior limb to translate through the bone tunnel, while the superior limb can be brought over the top of the tendon, performing a lateral row style repair at the end utilizing the metallic style button. Here the sutures can be seen being passed utilizing our prior passing suture. The sutures are passed with the passing suture in a collective group and then passed through the metallic button as shown here. Following the passes of suture, the button is secured utilizing a series of knots, and this reduces the tendon down into its anatomic position. Following the repair of the two Krakow sutures, the Mason Allen sutures are going to be utilized, and as you see here, they provide a more lateral row style repair. This creates a double row style repair for the subscapularis, providing adequate restoration of the subscapularis length as demonstrated in the image. Demonstrated here are postoperative images from the same patient. What you'll see is that the metallic button allows direct visualization of the repair integrity. Thus, postoperatively, you can be confident that the position of the button post-op is still there with your sequential postoperative X-ray films. In this case, this patient progressed well through their initial 6-week period and then progressed on to an active motion protocol with a demonstrated secure fixation of the tendon through this metallic button marker. Once the 6-week window has passed, the patient will discontinue the sling immobilization and begin active range of motion. At approximately the 10 to 12-week point, strengthening will be initiated. So some of the more interesting tips and tricks involved with this particular procedure is the ability to reduce the tendon to its anatomic position. For instance, if you choose to utilize a lesser tuberosity osteotomy, the drill tunnels allow you to position the sutures directly medial and lateral to this. By then placing your subsequent sutures there, you can ensure that you're going to get a near to anatomic repair by placing the sutures directly over and allowing for lateral compression as well as medial row fixation. In addition, these sutures offer you the opportunity to take advantage of some of the more dense bone in some individuals who may have more osteoporotic proximal humerus bone stock. That opportunity allows you to combine the dense bone of the biceps groove with a robust construct of a metallic button, giving adequate fixation in order to allow these individuals to be mobilized.